Good afternoon, everyone. Welcome back. Thank you so much for coming back after the lunch break, and I'm really excited to open our next session, which is our Industry and Policy panel. And to do that, I'm going to first start by introducing my colleague and friend, Dr. Loretta Arunce, who will be moderating this session. She's a surgeon scientist at City of Hope Medical Center, and she splits her time between surgically treating patients with thoracic malignancies and researching health inequity. So please join me in welcoming Dr. Arunce to the podium.
Hello. Hi, everyone. Sorry, I had to ask Trista a quick question. But, hasn't today been fabulous? Can we just give a round of applause to everyone, the speakers, the panels, our keynote? Dr. Hughes Halbert and her leadership has just created something phenomenal, and I am excited to keep it going. So we're going to, I'm going to ask that, oh, you can just put it there. Yes, I will. You're amazing. Trista's amazing, by the way. You guys know that already. So can we go ahead and have our panelists come up? So we'll have Trish McDade O'Neill come up to the panel. Thank you. And Ariel Brown and Jack Gallagher. Thank you. We're so excited about all the amazing things you're going to have to say. Thank you, thank you, thank you. And then we're going to do introductions of you guys after. Dr. Arun Krishna comes up. He's the Vice President and Head of the Lung Cancer Franchise U.S. Oncology Business Unit for AstraZeneca, and is responsible for overseeing all lung cancer U.S. sales and the commercialization of Tagrisso. Y'all have heard of Tagrisso. So he is the lead, and future lung cancer indications. We are very excited about all that he's going to have to say because, the truth is industry and our different organizational leadership is critical in this space. We're not going to do it alone, and we're so excited to hear your thoughts. So, Dr. Krishna.
Thank you, Dr. Arunce. So before I introduce myself, first of all, it's the after lunch lull, I assume, right? So did we get all our coffee and everybody's good to go? Good energy? Yes, good energy in the room? All right. I'll try and keep up that energy because, as I said, just echoing Dr. Arunce's words, I mean, this morning's session was eye-opening for me. And I was telling Dr. Hughes just this a couple of minutes ago, sometimes we, in order to create the vision like the people shared this morning, it takes a lot of effort, takes a lot of energy, takes a lot of passion and a lot of resilience, right? I mean, and the roadblocks that I'm sure we all hit each and every day is not a small thing, but we still wake up every morning because we are committed to the cause. So I just want to, again, a huge round of applause, please, for the presenters, for our moderators, for our panelists, and for the people behind the scenes who probably are not here today, just out there in the community working hard to make sure that every patient counts and every patient matters. So again, thank you for that. So yes, as Loretta introduced me, I am the head of lung cancer for the US, and I've been here now in the US for around 2.5 years, and I moved in from the UK, where the last 10 years we were there. And I bring up the UK deliberately because, for those of you who don't know, the UK health system is very, very different from the US health system, right? You have the NHS, which is the National Health System, which is very close and dear to people in the UK, to a point where they actually voting depends on how much they love or hate the NHS. But the NHS is totally funded by the taxpayers, and it's a single-payer health system, as we call it. And of course, it has all of its challenges because it was built during World War I, World War II, and it's very good at acute care. But one of the things which is good, and one of the things we can learn from that is, no matter where you are, whichever hospital you go, the care, or who you are, the care you receive is consistent and the same, right? And so there are a lot of things I think we can learn from them. But the story goes is when I landed up here, I thought, oh my God, we are in the US now, the land of the great, the land of the opportunity. I'm sure the health system is going to be absolutely amazing. right? And mind-blowing, and then everybody's going to get the best care because you see $20 trillion in spend, and everybody's in debt, but at least people are getting good care. No, that is not the case as well, right? So over the last 2.5 years, I've been to pretty much every part of the US, almost all of the 50 states, and the problems and the challenges and the opportunities are similar, right? I mean, the zip code you live in kind of determines the care you get, and you heard from the panel today, right? There's a lack of knowledge and understanding among the human population in terms of what is good care needs to look like, right? And then you have an overburdened health system, again, like anywhere else in the world, that people are scrambling, people are working overnights, they're working overtime to just do the basic job that they can. And so what I'll try and touch upon, probably in the next 15 minutes or so, a few things. One is, of course, I want to give you a big picture in terms of not AstraZeneca, but AstraZeneca as a company, we're kind of firmly cemented ourselves in the area of sustainability and health equity. And I'll kind of give you a global picture of what it means to us and how are we working with people across the globe to be able to address the challenges. The second part of my talk, I kind of move more focused into health equity in the US and how we are really trying to partner with organizations such as yourselves, to really move the needle across multiple therapeutic areas, multiple disease areas. And lastly, I always joke with my colleagues here who are sitting in this table, I should become a California resident because I come here almost every other month, if not, every quarter. And that's purely because of some of the amazing collaboration work that we have done with people like Dr. Runsei, with people like Amy Cummings and Jonathan Goldman. And I'll talk a little bit about the California Lung Cancer Consortium, which we have created last November, and how we kind of partner to really move the needle in terms of lung cancer care. So bear with me. I'll try and keep it dynamic, and of course, please interrupt me. Happy to take questions, comments, feedback as you go through. I'm not going to spend too much time on this slide, but it's sufficient to say that, okay, AstraZeneca, but I'm sure unlike every other industry partner of ours, we are significantly rooted across multiple therapeutic areas. And what you see on the slide is ranging from cancer to chronic diseases within cardiovascular or in respiratory field to rare diseases. We really want to make an impact and kind of move the needle in this space, not just with our medicines. I think I want to say this and I want to reiterate it. Moving the needle by medicines itself is not sufficient. We need to be able to move the needle across the entirety of the pathway, and our commitment is to be able to improve patients' lives. So for example, in oncology, we talk about eliminating cancer as a cause of death. And this is a very powerful vision for us here within AstraZeneca because we realize that it's just not medicines, but how do we entire pathway. I got some statistics, it's quite interesting. Over the next, in 2030, there will be approximately 30 million new cases of cancer alone, and there'll be an annualized death of around 17 million a year moving forward on cancer, right? And so, and you think about it and you say, oh, there's such good medicines, there's such good science which has come into this space, why are still, and you come down to the problem of, the equity issue, the burden of the disease, the lack of access to treatments, the lack of access to basic screening things. So I'll touch upon a little bit about it, but it's sufficient to say that this is the areas we really want to play in. I think this is an important context. Recently, as early as I think last year, AstraZeneca, our CEO Pascal Soriot signed a huge agreement in the UK across the world to our commitment to not just zero carbon but negative carbon by 2030. So emissions within the organization by 2030, and this is really important, right? And it comes to the climate crisis that we are facing. And the climate crisis, let me tell you, anywhere I go in the world, I look at the weather, of course, right? Because I need to know what to pack. But then the next thing I think people have started to look at is the pollution index, right? And you start to see that the pollution index in urban areas are so significantly high that are one of the biggest causes of respiratory illness globally. And you don't even know it because it's a slow killer, right? Like it takes time to be able to do it. So climate crisis And the impact of climate crisis in the burden of disease is pretty high. Systems are unable to cope with it. I touched upon this, and I think it's not a U.S. centralized issue. It's anywhere in the world. You go in, you have long waiting lines, long queues, people trying to get in to see the doctor. People are in primary care are overburdened with the number of patients that they have and the people they have to see, and the staff is limited. Right? The resources are limited. And so, how are we able to work around this? And then, as I said, health disparities keep widening. And then, I grew up in India, and every time I go back, it's a stark situation in countries like India and other Southeast Asian countries, because the divide between the rich and poor are getting so vast and so big that, health disparities just becomes quite significant in that space as well. I mean, as an example, like, median average, just on socioeconomic burden, like Southeast Asia, you have a 10-year variance of people based on their socioeconomic background in terms of death rates. So it's quite incredible to see some of it. And so, that is just going to, escalate as we move forward over the next 5 years. I'm not trying to put a dire picture here, but this is to a large extent the reality that we are all living in, right? More than 2 billion estimated to have a chronic disease, just coming up in the next few years, 400 million more with rare diseases in this space. Aging population. Now you look, there's good medicines. There are good medicines that we have that enables people to manage their lives. So whether they're living with good quality of life or not, it's a question that we got to ask ourselves. But it is managing their lives, and they're managing it well. But that becomes an aging population, and an aging population starts to create a heavy level of resource burden to an extent, because people are just living longer. But the money we have and the investments that we're doing and the taxes we are paying is still limited, right? And then, of course, health economic systems and the economic, affordability challenges in a lot of our geographies is a reality. And people have to make tough decisions in terms of how to prioritize. And how do you prioritize? Do you prioritize lung cancer over prostate cancer? Or do you prioritize respiratory diseases over cardiovascular diseases? And these are the tough questions people are asking, because they just cannot, spread too far and too thin. And so it comes back to what we have been talking today, right? Partnering along the entire patient journey to close these care gaps. And I think there are two components that I think is so important now for us to see. I think traditionally we saw a lot of care gaps on the right-hand side, but we never broke it down by the social determinants of health. We looked at care gaps, whether it's early detection, diagnosis, guideline-based treatments, or adherences, and you kind of look at a population level and you say, okay, this is manageable, this makes sense. But then when you start to break it down by the social determinants of health, maybe it's environmental, genetic, behavioral, social, you start to see that care gap significantly different. Right? You think about it like, African Americans in terms of lung cancer screening rates versus an average Caucasian male population is 10 percentage point difference. Right? Why is that? Right? And then you start to dig around in a lot of these areas and you realize that it is sometimes the social determinants of health. It is sometimes the zip code that you live in. It is the infrastructure that is there currently around it. And so some of these numbers at the bottom, I won't go through it, but I think it's great. See, eligible patients' access to lung cancer screening by variation state is 17x. So you have as good as Massachusetts, which are sitting in the high 20s in terms of, still low, but in the high 20s of lung cancer screening rates, and then you have other states which are as low as 1 to 2% of eligible patients who are being screened for lung cancer, and that is, I think, a tough one. And then 50% of patients do not take their medication due to financial reasons, and I think we talked about it this morning, and I think our keynote speaker, Dr. Soni, mentioned this, right? And we're doing a lot in that space, but it's still a pretty significant gap. So we feel that, just to summarize that global picture, we feel that there's a global kind of a challenge which revolves around sustainability and the health system's challenges that we as AstraZeneca, but we as an industry need to play a critical role in. If our joint vision and our joint purpose is to be able to improve patients' lives, and that's where some of this is coming on. So let me double click into now. Let's focus a bit more in the U.S. And I talked about this. So I'm just going to skip that and kind of look at our roadmap. The way we are designing it is under 4 pillars, as you see below. So when we talk about health equity, what does it mean? Yes, it's ambition to achieve health equity for our patients, but also our employees, right? We have 65,000 employees in AstraZeneca worldwide. 6,000 of them are in the US alone, right? So we also want to say, like, are we managing our employees well enough in terms of their health and well-being? And emphasize on those who are historically excluded and disenfranchised population. Oh my God, this sentence took a year to create. Now, I'm not joking. It is, because, the devil's in the details, right? It's easy to put a vision statement, but you got to be able to make it resonate. And using words like historically excluded and disenfranchised population is important. It covers a broad group, but it also sends out a message quite clear, I think. So we have under four pillars. I won't touch upon all of them, but I think I'll take maybe 2. I'll start with science, right? I mean, most of our investment in AstraZeneca or across any of the industry goes into R&D, right? To be able to do clinical trials. And this has always been a challenge for many, many years. I mean, I've been in the industry for more than 18 years now. And I think 15 out of which is, oh my God, are we addressing the right population within our clinical trials? Do we have diversity in our clinical trial population? And we have never been able to solve it. We've incrementally, gone a percentage or 2 up, but we've never been able to solve it. And sometimes it's the system, sometimes it's the industry, because the industry, we as an industry want to do fast and quick clinical trials. The system wants to kind of push clinical trials into the community, but we don't have the infrastructure to be able to do that. We don't have the resources to do it. So it's a little bit of a chicken and an egg problem. And then we land up in the same spot we were a year ago where, we want to do these clinical trials, and the academic centers are like, yes, we can do it, but we want to do it in community, but we don't have resources. Let's just go do it in the academic center. Right? So I think we have to put this front and center, and we really need to make this a priority, because I think FDA guidance requires it, of course, but it's just not meeting minimum criteria. It's about making sure that the population that we are living in here in the US and the trials are truly representative of the population, because then we really understand how the drug works and what's the safety profile for that patient population, and be able to clearly articulate and educate. The other bit is, and I'll talk about community. Transforming outcomes through community collaboration centered around equity. And I think, I do not take this lightly, that I think we are now in the era where whether you're in industry, whether you're in the community center, whether you're in an academic center, we realize that this problem cannot be solved alone, right? This problem has to be solved in collaboration, because each one of our parties bring in a level of expertise to the table. So why not use the level of expertise? And so health equity from a community place, we as AZ might not know the details of what the challenges are. But of course, if you talk to Dr. Urinsay or you talk to Dr. Hughes, you understand where the problems are and the challenges are. So how do we then co-create solutions to be able to address that? And I'll pivot to lung cancer, because I am in lung cancer, and this is something of my big passion. And so I'll talk a little bit about what is this concept within lung cancer, to be able to pull all of these 3 pieces of the jigsaw together. That's our vision. That's my team's vision, right? You have social determinants of health. Who is impacted, whether it's based on tobacco consumption, whether it's based on genetic profiles, whether it's based on socioeconomic status, and then what access barriers do they face within the entirety of the pathway? And it could be different for different things. So for example, early detection, screening, right? I mean, you could have a program in screening which has been accessed by only certain groups of people, because people have placed screening programs in those areas where other areas might not have it. But have we consciously looked at where to be able to place these screening programs? Have we looked at data to be able to understand that this is the area we need to do it, because that's where there is diversity in the population? We sometimes land up, doing things first and then reflecting later. Let's spend more time on understanding, okay, the data and what really exists before we start to create any programs, because then we're able to measure it clearly. But again, you see some of these barriers, low biomarker testing rate. I think I'm pleased in some way, shape, or form. If you look at the United States, I'm not 100% sure, but Trish, is it 16 states have the 16 or 17? 16, 18. Yeah, 16 or 18 states, which is great. It started with Kentucky, and now it's most states in terms of biomarker reimbursement. But it's not in all 50 states. So precision medicine is the cornerstone of lung cancer treatment as it stands today, right? It's not a one-size-fits-all approach. You can have multiple mutation levels. You are not even a smoker, and you could have EGFR mutations, you could have ALK, you could have ROS. But if you're not reimbursed and the state is not funding, the reimbursement of biomarkers, how many people can actually pay for it? And if they can't pay for it, how many people are actually getting a targeted treatment? And you know that the survival rates of patients who have, for example, EGFR positive, who get a targeted treatment, are 5 times longer to live than those who don't. And so these are the gaps that I think we need to kind of look into and really address, and this is where we're really trying to work on. And I'm really excited about this because one of the things we are trying to do is we are in the age of technology and data. And if you don't use technology and data, it's a remiss. So we are building a huge analytical platform, which will allow us to clearly identify the mix between the social determinants of health and the care gap pathways. And we are able to clearly pinpoint, for example, if you want to do a program in this catchment area, what are the social determinants of health you should be thinking about and addressing? And then what is the data saying? And what kind of programs within the care gap continuum that you should be actually utilizing, right? And so this is something which I think is the next generation of how we should be determining which programs to do, where and when, and this is something we are working on and with partnership with many people, and we are doing this not just in the US but globally, and I'm very excited about this. So for example, if Dr. Zool gets his lung cancer bus, to identify, screening, where do you go with the bus? How do you identify? Sometimes we have knowledge acutely, yes, because we have been in the area, we understand it, but can data really help us to say, okay, if we have a screening bus, how do we strategically use the bus to get maximum amount of impact for identifying patients? So this is my last part of my talk, and I'm really, really excited about this because this is something this team, Damon and Ariane and Natasha and others, I've been spearheading this for years. And this was even before my time. And it's a funny thing, as soon as I came in, it's probably day 1, day 2, Oriane cornered me here, and Damon, the two of them, if you don't know, you got to get to know them. They will sell you anything. They cornered me here and they said, Arun, this is the program we need to be able to invest because we want to make California really the bright shining star when it comes to cancer diagnosis and early detection and lung cancer screening. And so, really great job that has been done by them, and I want to just share some of the outcomes of this. So we started something called Screen California with our partners, and I'll come to our partners in a bit, to really kind of identify what I've just spoken about, right? Improve lung cancer care delivery, appropriate patients, expand optimal lung cancer treating, screening and resources to patients so we are able to identify them earlier and improve their outcomes. And so the first and foremost is you got to see where the gap is. So this was the stock data I got presented to as soon as I came in, and I was like, 1%? So this is what it was. So a few years ago, California screening lung cancer, and I think you brought this up today, right? Lung cancer screening rates in California is 1% of the eligible. Yeah, understandably, yes, the smoking rates in California are much lower than the rest of the other places, like the Midwest or the South, but still 1% I think is acutely low. And when given that, this is reimbursed and covered. And so this is the problem statement. So where do we go from here? Only one way, up, right? And I think that's the promise and that's the optimism I think the people working on this project really, really had. And so we kind of started with UCLA, and then we kind of wanted to expand and look at the whole UC system. And so again, we wanted to kind of look at what are the data gaps here, right? And so if you look at benchmarking to improve, you see the screening rates just across the systems. And so if you take the 6 or the 5 UC systems, you kind of wanted to, we said, okay, these are screening rates, it's very different across, and we try to identify, what are the challenges, what are the health disparities that exist, how do we achieve it? And the team, had a goal, like, let's increase it by 20% by 2025. So we are 2025 now, and I'll show you some results, which I think looks very, very promising and moving in that area. But this was not industry-led by any way, shape, or form, right? This was completely people who you see on this table, of course, spearheaded by Amy Cummings and Jonathan Goldman, who are, I think, one of the most passionate people in this area that I've ever met, and totally humbled to be in their presence. But they brought this this group together to kind of say, okay, we want to have like minds come together from the radiology group, pulmonology, people who could do smoking cessation, public health, policy, tumor, come together, create this University of California Lung Cancer Consortium. And they created this task force almost 3 years ago, to really tackle that issue. This is 1%, we want to grow it by 20%. How are we going to be able to do that? And we as AstraZeneca, because it was very much tied to our ambition as well, said, how can we support and help? And so the aims were very clear, right? Achieve lung cancer screening quality standards, uniform. So you see the disparity that exists between the UC systems. And you say, okay, we are all UC systems, right? Whether you're, San Francisco, whether you're in UC Davis, why are these things different? And let's try and raise the bar across the board in all of them. Address health disparities and barriers to access, fundamentally to screening, right? Like where are the health disparities that exist during screening? Put in certain programs, of course, tobacco cessation program. I think it's a low-hanging fruit. We could do that. Now we can do a lot more beyond tobacco cessation and prevention. And then you try and facilitate some research around it. In addition to this, I think it's really important to say that if you have lungs, you can get lung cancer. So there's a natural stigma, of course, to say, okay, you've been smoking and therefore you got lung cancer, which I think is a stigma that we need to help remove. But in addition to that, I think it's also important that people with lungs can get lung cancer. You don't need to be a smoker. There are so many people that I have met in the age of women, in the age of between 20 and 30, shocked that they have got lung cancer, right? This is genetic factors, hereditary factors. And so we also wanted to kind of look at certain programs. Across the state of California, we're working with Kaiser, we're working with UC Irvine and Hari to kind of look at studies to identify, to look at cohorts of studies to identify non-smoking, to then go put them to low-dose CT and then say, okay, what is the rate of lung cancer within non-smokers? And hopefully try and make a policy change in that space as well. So, but sufficient to say that, through these programs, through creating some of this stuff, we did achieve the goal. And so congratulations to the team. So I want to give a big round of applause to the team, to Amy, to a lot of them. And you see the rates all of them have gone up consistently. You still see the same trend though, right? You still see UCSF being lower than the others, but, but sufficient to say that, everyone has grown consistently through the programs that we've done, the cessation programs and all of it. And I won't touch upon all of it, but there's a lot of things that we did in partnership. With them, I'll come to the 5-year program, but the first and foremost was, let's use technology. And so this is my second platform that I'm talking about, right? Like, how do we create a digital platform so people can go in and self-identify themselves, right? And this was something led by UCLA, Amy Cummings and our team, to create this digital platform. People can go in, and it was available quite easily, so they can go in and see whether they're requiring to get a low-dose CT for their lung cancer screening, and it will tell them which is their closest screening center and book an appointment for them and a nurse navigator and so on and so forth. So, you follow through some of that stuff which we were at. It was amazing. We had a chance to, in December, go to the National Hot Rod. I never knew something like that existed. National Hot Rod Association, which is basically drag racing, where there's tons of big cars. And talk about pollution, so add a bit more. Add a bit more to that with diesel engines or whatever. I thought the Michigan should be having electric drag racing right now. I just never get this point of just burning gas. But anyways, it was an opportunity, right? I mean, we had a lung exhibition there. Was the first time we actually brought in, with our partners in collaboration, we had the Airbus, which is a bus which would do spirometry. We had the application from UCLA brought in, so that people could get tested on site. We had a huge lung experience to educate them. We had more than 5,000 people walk through that. So again, it's a huge impact. We had the local senator come in, the congressman come in. So I'm bringing that up because, a lot of the work that I heard today, sometimes the big policymakers don't hear about it, right? So how do you bring them into the fold? Because ultimately you do want to make a policy change, either in the local legislation level or in the Senate level. So how do you bring these partners in? They were so surprised about lung cancer screening because they had no idea, right? And so bringing them to such events, I think, is always a positive thing. And then The last but not the least is something which we are quite passionate about is research on IPNs. It's incidentally pulmonary nodules. You know, a lot of people come into the emergency room, they do a CT scan or a chest x-rays, and these nodules are so small, they go undetected, and then 3 years later, bam, they're diagnosed with lung cancer. So how do you able to detect these nodules earlier and sooner? We want to work on this collaboration with the UC system around it. And so there's a phase 2 now, and I'm really pleased. Like I met a lot of you in November when I was here. We have the 5-year collaboration. We have now changed it from, Amy has consciously changed it from UCLCC to California Lung Cancer Consortium. And this was done very deliberately because this is not a UC. Amy told me, this is not a UC thing. And so here being in USC, I want to really clearly land that message, saying that this is not a UC thing. It is a California thing. And so my humble ask to you all in this room is, reach out. I think this is a great consortium that we want to be able to do. And I will, it's we're moving away from Screen California to Healthy Lungs, because I think there's an opportunity here for us not just to look at lung cancer, but also expand this to look at respiratory diseases, COPD. If you just mine your data, you will be shocked the number of people who have been diagnosed with COPD get lung cancer. I won't tell you, the level is high, right? So how do you able to then, you look at a platform approach where you're really talking about a healthy lungs campaign, so to speak, and we have this formed, and you can see people from Cedars. You have, of course, Dr. Aronce from City of Hope. You have Dr. Zul, who's from Cedars-Sinai, and many more people, I'm sure, you would recognize within this. And this committee is, if I might say so, welcomes more people and opportunities to be able to come together and co-create big ideas, big thinking, but at the same time, really execute on some of it. So, with that, I do want to just say massive thank you for this opportunity. I hope this was, in some way, shape, or form helpful. I am, and of course, speaking for my team, very passionate about this. And I leave you with this thought that, we need to really look at the entirety of any pathway that you choose to make an impact of the outcome. And when you layer that with the social determinants of health, we will be that much more targeted to really improve our screening. And I'm confident that in the next couple of years, the screening rates from 1% go to 5 to even 20 and maybe even beyond. So thank you very much.
That was phenomenal. So thank you so much, Dr. Krishna. It's funny, right? Because I made the joke earlier that we had forgotten and weren't talking about lung cancer screening, and then he comes up. So thank you very much, because, we do need to be comprehensive. And so that's a great discussion. We appreciate your frequent trips to California, because good things are happening with you here. So, and again, thank you for our AstraZeneca team. Y'all are phenomenal. I like all of you. So I want to also introduce the rest of our phenomenal panel. We've got I'm really excited about the discussions that we're going to have amongst the whole group. So Trish McDade-O'Neill is the Director of Corporate and State Government Affairs for AstraZeneca's West Coast region. She has extensive experience in biopharmaceutical advocacy and excels at shaping public policy, leading state-based lobbying campaigns, and forging strategic alliances. So certainly very excited to have you with us. We have Ariel Brown, who is a social media specialist at Acclinate, a Black and woman co-owned health tech company on a mission to empower communities to take action for better health. Ariel has achieved significant growth at Acclinate's now included platform by using data-driven approach, which I really hope that we can really dig into during our panel discussion. And then Jack Gallagher. Has over 20 years of experience in delivering important medicines to patients. He currently leads Access Solutions, Genentech's Center of Excellence for delivering patient navigation, case management, and financial support services to patients across Genentech portfolio. So again, I just want another clap before we even start. Because you're going to get hard questions. So honestly, if you have questions out there, please somehow let me know, because I definitely have questions that I want to start with. So We wanted this session because it is so very important. So, even last year at this symposium, there was discussions around the importance of driving policy and really bringing our industry partners to like the table so that we really move forward. And I think especially now, right, with all of the different things that are happening with the budget and funding cuts, with the sort of executive orders that have come out. So you talked very strongly, and we have been around about health equity, but again, there's a lot of discussions about that being sort of rolled back. So I was hoping that each of you would maybe start the conversations around what you feel the role of industry is and your respective organizations is in focusing on health equity around patient navigation specifically in this current climate. Like, what should we be doing differently so that we can get it done? Okay.
Thank you, Dr. Yee. Appreciate this time. And gosh, I'm just learning so much just having been here today to hear from all the community partners and all the great work everyone's doing on patient navigation. On behalf of AstraZeneca and some of the work that we do as an industry advocating for policies in Sacramento, for example, the work that we do try to align pragmatically with what is viable, what we can get done. And so we work with our stakeholders and policy influencers in Sacramento, specifically looking on what can help drive care, improve access to care for patients. And listening to some of what, identifying what are the barriers to care and helping patients along that treatment journey. We kind of plug in, and at least with our industry, working with patient advocacy organizations quite a bit and identifying, they know firsthand, what is really relevant and what are the needs, especially dealing with, some of the current uncertainties with the payment reforms and potential cuts to Medicaid, et cetera. So we look for solutions that we can, put forward, and knowing that we just don't give up, that, it might take a year or two. We might have to go through some, but you have to keep advocating. You find alignment, you work and develop coalitions, because that, to me, is the power of, policy, is having, coalitions that are aligned on a unified approach. For example, the biomarker testing, just advocating so that patients can navigate and get to better treatment outcomes. A lot of organizations, patient groups across all disease states got together and aligned on legislation to advance a couple of years ago, and it actually passed in California. And that brought forward better access to care. However, we still need, we still have to keep pushing and recognizing that there's, again, increasingly more obstacles put in place and challenges that patients face, and helping patient navigators and even helping educate the community health workers as well, and supporting the efforts with the promoters, for example, to make sure that they have the information and data they need to advance and educate patients for care is important. That's what we do in advocacy, is bringing together coalitions, strengthening them, aligning on policies that will help advance, and educating and providing venues where I also support, and a lot of our industry are part of the Cancer Caucus in Sacramento, where it's actually supported by the medical oncology societies, as well as many of the patient advocacy groups. They come together, and we're industry partner, and we just raise awareness as well on care gap needs. And for example, lung cancer screening being such a need for removing barriers, we helped support a legislative briefing with that Cancer Caucus, so that over 100 legislators and staffers were participating in this briefing, hearing firsthand what are some of the obstacles to care, what are the care gaps that need to be fixed, that in policy solutions they could advance to solve for those gaps. So that's sort of what we do. We just really try to raise the coalitions and support them the best we can, and just look and be open to other advocacy organizations, what you want to bring forward as well, so that we can support, always being open to those possibilities.
That's awesome. Thank you. So our advocacy, education, and raising awareness. Ariel, thank you.
Yeah, that's a great segue for what Acclinate does. So as you mentioned, continuing to just lean in to what is going on with all of the things that are happening. It's been brought up in several meetings on our side of the table, all the banned words that have come because of DEI and rolling back on certain things. But on the social media side, you know, the DMs are on fire as far as people talking about all the different things that are going on. And so we're really listening to what our community is needing and leaning into those things that they need. So just because there's certain things that are going on in the political space that might not quite align with the work that we're doing, we're continuing to serve the needs that the community is asking for and making sure that we're that space for people to come to. If they need, you know, specific health resources, they know that they can come to Acclinate and or to Now Included and to be able to find those things that are tailored to them and that allow them to just kind of understand and have a greater connection with those sorts of materials. So continuing to lean in, and then also making sure that we are talking to industry partners like yourself and making sure that, you know, we are working together and co-creating those solutions to engage the community that we need.
Thank you. And really quickly, Ariel. I really appreciate that. Can you just enlighten us and tell us a bit more about Acclinate and Now Included specifically? Because again, these partnerships are so important. So.
Yeah. So Acclinate, as is in my bio, our mission is to empower communities to take action for better health. And what that means is that we do it through an omni-channel approach. We have both a touch side of our business as well as a tech side of our business. So on the touch side of things, we are going out into community and really meeting people where they are, as was mentioned a lot in our last panel. But for us, that means in the DMs on social media, but also going out into the community and talking with people about all the different things that they need. And then on the tech side of our business, we have several different products, Now Included being one of them, where we are working with industry partners to allow them to better understand when is the proper time to offer a clinical research study with the different community members that we are connecting with out in the streets or on social media. We are working with them so that they have a better idea of exactly when is the appropriate time to connect with those people and engage with those people, and we do that through our effective trust framework. And so we are continuing to sustain engagement post-touch through our tech, and then working with these partners to allow them to kind of have a better understanding and also just get more of their information out into these communities, because we are that kind of liaison or trust partner. Yes.
Excellent. Thank you. Yes.
This is such a great question to start with, because by chance, I've spent the rest of this week in Washington, D.C., trying to advocate for these things we're talking about, and it's a very, very difficult time to do so. It's really, really uncertain. And so over the time in D.C., I had the pleasure of sitting down with several of us sat down with several patient advocacy groups, including the American Cancer Society and Cancer Care and Allergy and Asthma, and they're fearful. They're fearful for the cuts to Medicaid that may come. They're fearful for the impact to the exchanges that Dr. Soni mentioned. They're fearful about the rollback and the backsliding on the tenuous but really meaningful gains that have been made in terms of advancing inclusive research in our clinical trials. They're worried about that. And what are they doing about it? To what everybody said, it's about listening to patients, partnering and building coalitions across all parts of the healthcare ecosystem that knows what patients actually need. And it's then about advocating for them through whatever channels we have. Like throughout this, I've learned so much at this meeting from some of the avenues that Dr. Soni and others in the earlier presentations were talking about, ways we can advocate and raise our voices and make sure we're present in the right conversations. The inspiring thing, an optimistic thing I found from being in DC was, after talking to the patient advocates, we then went to the Hill and we talked to some lawmakers and their staff across both sides of the aisle. And yes, you have to be very thoughtful about how you frame arguments and even use language in ways that we didn't have to in the previous administration. And you can still have impact and make progress. I was there with a group of our board of directors for the Genentech Patient Foundation. This is the independent program that provides free medicine for 75,000 patients a year in the US who can't afford Genentech medicines otherwise. And so that board of directors was there to advocate for what they know to be true in terms of the challenges that people face when they become patients and need access to medicines that they can't afford. And when you get down to local House members and their staff, they care, they really do on both sides of the aisle about the impact to their constituents. And we had to work on our arguments. With this administration and with Republicans in general, we may need to dial up the economic impact in addition to the patient stories. But it's not a one or the other, it's a both and. We need to tell the patient stories, we need to advocate for what's right, we need to be a part of the conversation, and we need to come up with arguments that matter to the people that have more power at a given point in time. So it's not hopeless, but it's hard. And it's hard in this environment. And if we keep all leaning in and doing everything that Trish was saying and everything that Ariel was saying, like this will be a moment that we work through and we hold on to as many of the gains as we can and we continue to make progress again. Because I think Dr. Soni said this, the arc is progress, especially here in California. You know, Genentech next year will be 50 years strong as a California company. We care deeply and we need to partner better than we ever have before with all of you so that we can make sure Californians are healthier than ever in the future. And I think we can get through this moment of adversity that we're all facing. But it's hard.
Thank you. So first, in many ways, your comments are inspiring because I think it's really easy to be sort of dejected, right? And so the reminder, one, that across the aisles, folks care. I'm not judging. I'm not, you know.
It doesn't seem like they do from a distance, but
yes,
you get up close with
okay.
people that know the issues. They actually do care. They're human beings. They want people to get health care and have access to it. They have
do
different
want
ideas of
people
how
to
to
have-
achieve
okay,
it,
okay.
but they want that outcome.
Okay, all right. Yeah, so I want that to be true. Were there any other questions? Oh,
Good second.
no. We have, there is can we have a microphone right here? Thank you. you,
I do
guys.
have a question. Thank you, by the way, for the presentation and everything. I was writing some points, and I was wondering in terms of when new technology come to the market and it take time to adapt, and then, the price tend to always be high. And in this case, we're looking for health equity. How do you think that this new situation and current economy, politics happening in the world, especially also, I'm sorry, said in Spanish, also in United States, how do you think that those things are gonna be affecting now more those next innovative new therapies? Because from my perspective, I think the health equity will be more challenging to achieve these days. So how do you think as a company, Genentech or AstraZeneca, will address those points without having to get affected also with the government and being canceled basically or something?
Excellent question. Please.
It's spot on, right? I can't see you, so I'm just going to stand. Yeah, so look, I mean, of course, the economic impact in terms of what's happening, but also in terms of cost of goods. And I mean, you look at new technology, let me give you an example. The next foray of technology, when you look at cell therapy, is going to be expensive. And of course, when you look at industry people who are working in this area, they think about, okay, how do we make this sustainable and scalable? But there's concerted efforts that are going to try and make this affordable enough to be, so it could be common grounds. But that said, I don't see that happening in the near term of the horizon, but hopefully in the long term. And that's why I think, look, we got to be, my take and my personal feeling is we cannot be everywhere. We need to prioritize, right? So we need to be able to clearly identify using data technology where exactly we are going to invest, right? And how are we going to measure outcomes? And my second part actually is way more important than the first one, because more often than not, I have seen studies, I've seen efforts that go into with the right intention and mindset, but over the time, either people not lose interest, but just it takes time to get the right outcomes, and the outcomes never come out the way because we don't capture it intensely enough. So I think there are two. So just to summarize, I think there are 2 points. I think one is we don't spread ourselves too thin. We got to be really focused in terms of where we can actually maximize our impact. But secondly, let's have a clear plan to kind of show and measure outcomes, because ultimately, to what Trish and others have said, is that if you don't have the right outcomes captured, you cannot, going into policymakers and making a case is pointless. I mean, I know you did, the 2 sites that you had for the screening one, which is great because, you collected data, you were able to kind of invest in the outcomes, and then, let's look at the economic impact of what it has done, and then make a case through the coalition to your partners. It's a long game. Right? It's not going to happen overnight. But again, don't spread yourself too thin, and make sure you capture the right outcomes, so then you have the right case to make with the right stakeholders. I don't know if anybody else wants to.
If you don't mind, I'd love to also follow up on your question earlier regarding engaging pharmacists as well. Part of our, AstraZeneca, we're not backing down on our commitment with health equity and in increasing diversity in our clinical trials. Los Angeles, we do have a dedicated clinical trials bus that we are deploying throughout Los Angeles. And we're actually partnering with some of the local pharmacies to be able to host screening events and recruitment. So it's just really, we're not going to give up. And I think that those kind of innovative strategies will continue. So thanks for that question.
Okay.
Please, yeah.
I can piggyback a little bit off of the pharmacy conversation. So Acclinate has done very similar work as far as connecting with pharmacies and then going out into communities and surveying community members on how they feel about, where they seek health or where they seek care. And a lot of the time it is a pharmacist over a physician, and so then that informs the kind of content that we make, that informs the kind of work that we are doing, and that informs how we also speak with our industry partners. And so, again, I feel like I'm kind of beating over this point with, but meeting people where they are and really listening to them is what we are all about, and that helps for us to find that place to move the health equity needle forward. So yeah.
We have to use technology and data to re-engineer our clinical drug development process. And all the companies are, everybody's attempting to solve this same challenge. We have to be more productive. We have to be more cost effective. We have to continue to bring amazing medicines. Then we have to price them responsibly. And then we have to support the heck out of them with health economic data to show that they're net of value to society and to even employers and insurers, so that they have access, there is easier access for patients, because everybody can get on the same side of the table with something that's got a positive value. And so as long as we do that, this isn't bleak, but it's hard. We've got to work harder than ever, and like everybody said, we've got to use data and technology to make that happen.
So added on to that, what work is being done, either individually or collectively, which would be great, to articulate the return on investment in health equity in this space? Like, right, like how do, especially if you're in front of the policymakers, everyone's looking at that bottom line. So where are we there, and how are we articulating that?
I'll make it very, very specific as an example, and I'll use lung cancer to do that. Look, I mean, Loretta, but I mean, I just for the group here, right? Like 70 to 80% of patients diagnosed with lung cancer are diagnosed at the metastatic stage. So one of our vision at AstraZeneca is to be able to diagnose patients earlier and treat them earlier. And so we started to create and invest in R&D in medicines within the lung cancer space and now beyond, to ensure that patients are diagnosed earlier and so can be treated with a huge chance of cure potentially. Yeah. And so when you start to look at the economics behind it, and now you split that by health equity or diversity or however it is, you then start to look at the economics behind it to kind of say that, you could look at productivity gains, you look at all of the different factors that are driving a cost effectiveness element to it, to say there is so much more value that, by doing this, you're able to pay back either to the system, to the provider, or to the patient, right? So one is there's a shift and pivot in the strategy of making sure that we go earlier in terms of development of medicines, but it's no point in doing that if no patients are being screened and detected earlier. So you start to invest in that. And now you make a totality of a health economic argument to say that if you're investing enough in R&D in the earlier side in medicines, and then you put enough of investment and resources together with governments, with policymakers, the total impact when it comes to society and community is a net positive impact. And that story in a lot of other markets do land pretty well, including the UK and other cost-effectiveness market. It takes a little bit time here, but the argument is still stands water, and slowly we can push the boundaries.
And we are making that argument now to our
policymakers and to our customers to kind of make sure that they understand, and we try and simplify it to a way to kind of say that, look, this is what net benefit is for your community, for your constituents. And how do we able to show that, both figuratively and through data and all of it, I think resonates. And they are the ones who go back up on the podium or, to legislation and start to make the case. I don't know if anybody else.
Yeah, I mean, you're spot on, and it's hard work. You just got to keep going, and you've got to be specific and meaningful to the people you're talking with about why it matters to them. So we met with some folks from Georgia this week, and we were able to bring them data on patients in Georgia that are or aren't getting access to certain medicines or suffering certain disease burdens, and they pay attention when you're talking about their world. Right? They care. This is where they care. Now, they care along a continuum and have other things they care about too, but we have to do that hard work and make it real for people, and then they want results. They want the money we're putting into healthcare to lead to outcomes for patients.
I was just going to add on to your point, if you don't mind. We often with the lawmakers, and we ask for changes or requiring the state to possibly increase some mandates to provide better access to care. They do want the outcomes data to really justify why, the whole picture of long-term data on how it will impact health, but also the economics of taking care of people sooner, better outcomes.
Yeah, and I'll just add on the community side of things. Every time we go out into community, we always survey and ask people, how many times, or have you ever been offered the opportunity to participate in a clinical trial? More often than not, that answer is no. But we also ask, if you were given the opportunity to participate, would you? And more often than not, that answer is yes. And so those are data points that we then take back to our partners and let them know, both with industry as well as with government officials, like, this might be something that could really benefit your constituents, and that you could, really lead the charge on health equity within your community. And so Acclinate is based in Alabama, and we have a partnership with the mayor of Alabama there, and he's very much like, Acclinate, and is very involved in his community there. And so he's been at different community events with us before, and when, his constituents see him being out there and in the community with them, then that makes a huge difference in how they feel about, that affective trust and really building those sorts of things. So, yeah.
I appreciate that. Trista has a question, but these conversations are important, and the linking with communities and patients is so important. The dollars are shrinking, but people will still die from cancer. So how do we make the people who have the purse strings get it, right? And so I hope we continue to have these discussions and come up with real, convincing talking points. But again, I'm inspired by what you guys have experienced. Yes, Trista.
Excellent conversation. We have a question from one of our guests online. Do you think the possible use of real-world evidence to inform regulations on therapeutics could help lower the cost of new therapeutics and increase access compared to traditional clinical trials? And how can we make sure to include SDOH data effectively in real-world evidence?
That's good. That was good.
Who wants to take a crack at that? That's a big question. Real-world evidence is something we have to generate more of. As the question implies, we historically develop it after products come to the market, which I think is appropriate. I think you need to test medicines in a controlled clinical trial environment to bring them to large groups of people. I think that's just the right way to do things, even though it's hard and it can be costly and seems slow. We have to work to speed it up. We have to make sure the FDA stays intact through this moment we're in, and that we can keep bringing new medicines. And we have to push ourselves harder to have those real world evidence plans in place beforehand and to be generating outcomes and other data alongside the clinical trial plans as they go. I think that's the way you get through it, is you beef up the approach we take to clinical trials so that you start with more in hand at the beginning and you're committed to following it through with real world evidence once it's approved.
Yeah, so as a mathematician, I don't think clinical trials is ever going to get replaced, and I don't think it should because, to your point, it is the gold standard in order to make sure whether a drug works or not. But that said, there are different ways of going about doing the clinical trials, right? So can we look at pragmatic clinical trials? So looking at data to enroll patients. How many of us, actually we have data connected systems within the health system where you're able to kind of ping to say, hey, this patient could be enrolled into this trial or this trial. And so you can recruit much faster and at a much lower cost. Most of the investments that's happening right now in clinical trials is going through contract research or CROs who are doing this externally. So how do we able to bring this again at low cost and use technology? The second element is real world evidence, again, is, how are we being smart about generating data in the real world evidence setting? Is using your own data is the best way to do it, right? Like, mining your own data. I know a lot of, academic centers, but also community centers here in California do look at their data on a regular basis to see how is the drug performing in the real world setting compared to clinical trials. So the more you kind of do that on a continuum basis, I think the more information you're able to get and build, but I don't think it'll ever supplement a clinical trial. Sorry, I just stand up because I can't see you.
Yeah. I don't think anyone brought in the social determinants of health aspect of the question, though, so.
Oh, yeah.
Yeah, let's do that.
Let's do that. So, I can bring in, and of course, please, guys, build on this. So the social, okay, so I mentioned this earlier, FDA guidance is about having diversity in clinical trials, and it's kind of a mandate. I think it's 17E or whatever it is on their list. But as I said earlier, the challenge in terms of bringing diversity in the US in clinical trials has been historically a challenge. And I think one of the biggest ways it can be solved is moving clinical trials into the community setting. Yeah. And that has to happen. Community sites need to start enrolling the patients, and it cannot only be a central academic center. So, for example, if you have the social determinants of health, low socioeconomic thing, they're all not going to come to the academic center.
Right.
They will go, and because they trust their local person there, they will be more, to your point, engaged to kind of get on to a clinical trial site. There's so many clinicians in the academic center have told me that, there are people who are coming from different socioeconomic backgrounds and thing, and when I ask them about clinical trials, they look at them and say, are you telling me that because of my background? Right? So there is itself a natural stigma that sits within that. So we have to move it to the community. It's going to take time. It requires heavy investment and heavy resources. But unless you move trial setting into the community, we will never be able to address it.
And in each of your organizations are doing that. That's a huge
element.
Okay, so
it's a big part of it. I mean, we have certain targets and goals that we have going to have in the next 5 years. So to double, if not triple, our US enrollment rate into clinical trials. And the only way we can achieve our own goals and the targets of clinical trials is when we have it in the community.
I'll just quickly add on to that. I think it definitely is adding into the community, but then also I think there's just a lack of knowledge and education from people that we speak to all the time. A lot of the time we'll go out and ask, would you participate in a clinical trial? And if the answer is no, then we'll ask why. And they say, well, I don't want to be a guinea pig. And that is like such a common answer. And then, we have to go and explain the Tylenol you take went through a clinical trial, or like the lipstick that you're using went through testing, and so there's all of these kind of barriers that people face, and a lot of the time it is just not knowing. And so for us, it's about breaking that down, figuring out how we can let people know a clinical trial is not scary, that, you know, things that you really got to be fearful of. It is really just an opportunity for your voice to be included. And that is the whole philosophy behind what all of us here are doing, but especially what us are doing here at Acclinate as well.
I was just going to add, based just exactly what you were saying, that community engagement. For example, we do have the clinical trial bus that we do bring into the community for underrepresented areas, but we do need to know, like, have that approach with the local communities and the feedback with our partners to really, are we approaching the trial recruitment correctly, you know, aligning with what's relevant to that community that we're engaging. So it goes hand in hand, that those community engagement and cultivating those partnerships are so important for us.
The quick thing I'll add is we overcame some of our own biases as we started to do this with more intentionality. We had still have something called the Advancing Inclusive Research Site Alliance, where we, in a focused way, went to different sites with an intention of enrolling patients that are more diverse and that suffer from different social determinants of health. And you know what? Those sites, once they got stood up, they enrolled faster than traditional sites, more patients faster. They blew away our expectations and their expectations. It just took focused investment and partnership, exactly along the lines of what Ariel said. How do you have a different conversation with patients who have different barriers to enrolling in a clinical trial? That was a big part of it. And now we've just got to scale that approach. And so it's intentionality, which has been a theme of the day, and you can really make significant progress, and it actually makes your trials enroll faster.
Yeah, and it's better for us.
And it's better
It's
than
better.
all of the other
Yeah.
things we thought it would get, but it actually was faster too.
Yeah. All right, I think we are done. This was fantastic. Thank you.